Hello everybody, welcome to the Skin Diary podcast. We are here today with the very wonderful Tamara Griffiths and my co-host Clare, Kiely over there. Tamara, you've had an incredible career. You are a board certified dermatologist in the US, a senior consultant dermatologist here, an honorary lecturer at Manchester University. You've won awards yourself and your clinical team has won awards, which is no mean feat. You've also been instrumental in pushing for changes to regulation in the UK in terms of cosmetic procedures, which is vitally needed, and in developing a blue tick so consumers can actually tell who is a consultant dermatologist, because people may not be aware that you can really call yourself anything. So we do need this kind of blue tick so you can differentiate between who does have qualifications and who doesn't. And you're also the president of the British Association of Dermatologists. That's kind of amazing. And you're also the head of product innovation for the Skin Diary, working alongside the lovely Clare, who is a consultant dermatologist with a master's in aesthetic. Is it aesthetic or cosmetic dermatology?
A master's in the course that Tamara actually founded in skin ageing and aesthetics medicine. Yes, I help Tamara now and I lecture on the course. But how lucky are we to have such an amazing president of the British Association of Dermatology here today to speak to us.
Absolutely. And skin ageing, why? What made you interested in that particular part of dermatology?
Well, really, my interest in skin aging stemmed from my training. So I trained in the States at the University of Michigan in Ann Arbor, and at that time there was a lot of seminal research in trying to understand what skin aging was, what a wrinkle was, because there was a topical product at that time called tretinoin, or all-trans retinoic acid, which was shown to be effective in reducing wrinkles and photodamaged skin. So really my interest stemmed from the serendipitous place where I trained in Michigan and the timing of that trajectory of research into skin aging and photoaging at that time. And we've moved on so much over the past 30 years in terms of understanding intrinsic aging, which is chronologic aging, extrinsic aging, so environmental factors, primarily UV damage from the sun, but also other environmental factors like pollution, high glycemic index, high sugar diet, emotional stress, poor sleep. All of those things can impact our skin and the way our skin ages and contribute to accelerated aging. That's how I developed my interest. And again, the field has moved on so much. It's been a joy to be a part of and to help understand what is happening in such an important organ in our body.
I think Tamara was really ahead of her time, to be honest, because when she developed the Masters, I mean, how long ago is it now? 15?
Just 10 years we've developed. We've got over 200 students.
Yeah.
But,
Wow.
Because skin aging at the time was kind of seen as slightly trivial, I think, in dermatology, you know, compared to all of the other skin diseases that we kind of treat on a day-to-day basis in dermatology. But I think now actually skin aging is coming more to the fore because it's seen as a kind of a master risk factor for so many other of the diseases that we treat. But Tamara was really pivotal in bringing that knowledge, you know, from Ann Arbor to the UK, and then in founding the department in the University of Manchester, where a lot of the research has been going on and is going on for the last however many years.
So contributing to the department in Manchester certainly have been a real professional highlight. And I think, Clare, you're exactly right. You know, there was a time when we thought about skin aging as strictly a cosmetic problem, you know, but we understand from the immunology, from the functional aspects of skin aging, that actually skin aging, we now have moved on in our thinking to longevity and well aging. So we want our skin to remain healthy, to do its job, you know, until our last breath. So it's not really about the cosmetic aspect or how we look, although healthy skin does tend to look better. So it's really moving on from cosmetic and regeneration to sort of promotion of longevity and health span of the skin. So it's a functional aspect of the skin that we're also interested in, because different forms of photoaging can cause problems like skin cancer as well as wrinkles. So these things are not separate and they're not in silos. They kind of all work together, underpinned by one of the theories of aging, which is a low-grade chronic inflammation that can cause problems in the skin, but also other organ systems in our body.
Yeah, we'll come back to that in a moment. But when it comes to the skin itself, What changes do you see as we age? What's actually happening to it? Why is it happening?
So true chronologic aging, or changes in the skin due to the passage of time, are relatively subtle. So if you look at an elderly person's back or their abdomen, which has had perhaps very little sun exposure, the skin might be pale and white and slightly wrinkly, but doesn't have the marked changes we might see on the face or the forearms, which are chronically sun-exposed sites. So we have to make a distinction between chronologic aging and extrinsic or environmental aging. With chronologic aging, it is impacted by genetics, but we see thinning of the epidermis, the top layer of the skin, the barrier function is diminished, and the deeper layer of the skin, the dermis, becomes what we call atrophic. So the cells are weaker, the fibroblasts don't produce as much structural protein and collagen and elastin, and we get thinning, and this can result in poor wound healing and tearing. And then very critically, we also have a reduction in the immune function of the skin. The immune system in the skin is critical in terms of fighting off infection, pathogens, and also repairing damage from, for example, sun exposure. So when the immune system becomes less effective at doing that, we develop skin cancer. Some of the extrinsic changes we can see on one extreme would be very sallow, leathery looking skin with deep creases and sagging. So that is called the hypertrophic phenotype. But there are individuals that manifest environmental aging slightly differently, where they might have very smooth, shiny skin, which is slightly red or pink, but they can develop other problems frequently, such as the keratinocyte cancers like basal cell and squamous cell carcinoma.
Yeah, that's really interesting, because you did a study apparently that was sort of looking at the differences. So if for somebody, your beautiful products have helped make my skin a lot smoother than it was before. But I am that pink smooth person. I've already had 2 basal cell carcinomas and a couple of squamous cell carcinomas. Thank you. Why is my smooth skin more likely to develop cancers than somebody with the wrinkles?
Wrinkles can be protective in some ways, but that's because one of the key proteins in the skin, the fibrillin microfibrils, which are basically the little hooks that connect the top layer of the epidermis to the dermis and result in sort of taut, more elastic, robust skin. When those fibrillin microfibrils are destroyed, we get laxity and wrinkles. So that is the problem with destruction of the fibrillin microfibrils. And we know that the fibrillin microfibrils can, in some ways, act as a sacrificial protein. So as the skin is hit by the UV, the fibrillin microfibrils can be impacted, absorb the UV, and degrade, and that results in wrinkles. There is a phenotype of patients who don't have as many wrinkles, but they have very smooth, shiny skin. They kind of might have a baby face and a little bit pink. So their fibrillin microfibrils are intact. They're not absorbing the UV, but as a consequence, the keratinocytes, so the skin cells in the epidermis, will take the hits from the UV, resulting in atypia and reduction and degeneration into potential skin cancers. So, there's pros and cons.
Wow. Is this something with your skin cancer work as well then? So if you see the smooth pink type person, are you telling them you've got to be extra careful?
I mean, we tell everybody that they need to be extra careful, but we don't really delineate between skin, that type of skin type, particularly with our advice. We do actually even see it sometimes mixed, where people can have both. They can have some parts of their skin where they have that atrophic pink type skin, and then some parts where they have the deeper, thicker wrinkles. But it's been one of those things that we've always kind of seen in clinical practice for years. So again, it's so nice now to have research that explains why and what is happening at a cellular level. And as we understand these processes more, we then are able to understand and think about new ways which we can, prevent aging, but not only aging, skin cancers and all of the other kind of sequelae of aging and the immune suppression and inflammation that Tamara was speaking about.
So I just reiterate what Claire said. Those are the 2 extreme phenotypes, hypertrophic and atrophic, but there are people that can be in between or mixed. I certainly would not say that if you're very wrinkly with sallow skin and coarse lines that, you would never get skin cancer in your protected, but there is a degree of protection offered by that. So I think it's interesting to understand that. And the second point is absolutely, it's the clinical observations, things that we observed in clinics, and ask the question, why is that drove the research? And I think that clinical observation driving research is really critical in terms of translational therapies that we can develop as well.
Yeah. You mentioned before extrinsic things that age us. Why is that the case? I mean, we've got things like people using sunbeds, which is just why do people use sunbeds, and what do they do?
I think sunbeds, it's very controversial in some ways. Any kind of UV radiation is harmful to the skin, and that includes sunbed. There's no such thing as a safe sunbed. Sunbeds tend to be very under-regulated, so there's a voluntary regulatory scheme, but really it's not regulated to a high degree, and although it is banned for under 18s, we know there is practice where children are still having access to sunbeds. Why do people use sunbeds? I think there's a whole host of reasons, but I do believe there is still an aspirational quality, particularly in the UK, where people want to be tan, and the message that actually being tan is actually your body demonstrating that harm is being done. We need a certain degree of UV to produce vitamin D, and I'm not saying absolutely no sun at all. I think we need a balance, but sunbeds is an unnecessary extrinsic factor in our lifestyle that is causing, potentially driving problems. So I tell my patients, if you like color, use fake tan.
Yep, absolutely. They are banned in many other countries in the world. In Australia, they've been banned for at least 20 years or so. Yeah. You're pushing quite hard to get better regulation here. What's the stumbling block?
Again, I think it's a very controversial issue, and there are a number of groups that have differing views on sunbeds. And we respect autonomy. We don't want to be a nanny state. But on the other hand, there are recommended regulations for sunbed use which are not being enforced. So the first stage would be better enforcement of the regulation that's already been agreed, moving from a voluntary to a more mandatory regulatory system. And then, there are other steps in preventative medicine in general. So one of the government initiatives is to go from treatment to prevention, and we're seeing prevention, health promotion being encouraged through better eating, reduction in advertisement of, fast foods, so banning on smoking in public places and eventually making it illegal for younger people to smoke. So this is the trend we're moving in, and hopefully we will see that sort of trajectory in the use of sunbeds. But it's a very complex area, and there are many stakeholders that have different views, which must be heard and respected as well, but incorporated for public safety and benefit of public health ultimately.
Yeah.
It takes a long time for the psyche to change. When you think about smoking and cigarettes and how long it's taken, still not banned, but they're just very, very highly regulated and highly taxed. And that has even just changed the mindset that people now understand, because they're highly regulated and highly taxed, that they are actually very bad for you. And also from repeating the message about lung cancer. And I think that's what we're trying to do in dermatology. We're trying to just repeat the message and explain and educate people so that they can make an informed decision. Because, as Tamara said, it's difficult because people like to look their best, especially nowadays when social media is so prevalent and everyone's very self-conscious, and there's a lot of appearance anxiety, and it seems like such an easy thing to do, to hop on a sunbed, but it's such a high dose of UV radiation that it really increases your risk of all forms of skin cancer. We talk about melanoma a lot, but the more common forms of skin cancer, squamous cell carcinomas and basal cell carcinomas, which you have your own experience of, are also increased from using sunbeds. And also, for any younger people who might be listening to this, the risk of wrinkles and aging is dramatically increased and really accelerates from using sunbeds. So, while it might momentarily look good for a few weeks, the tan fades, but the damage will remain for a lifetime. So it's really, really not worth it. And fake tan, they have this thing, I know some of my colleagues in Ireland promote this thing called Fake Tan Thursday, which I think is great. Yeah. So, because you need to put your fake tan on Thursday, and then by, the weekend, then it's looking good. And definitely promote fake tan. Obviously, there are the naysayers who say that there are chemicals in fake tan. However, they are very, very regulated. Cosmetics are regulated, and anything that we're putting on our skin goes through lots of toxicology and cosmetic regulatory boards. So we know fake tans are safe. The tan actually just stays in the top layers of the skin for a couple of days and then sheds off the actual pigmentation. So being a pale, pasty, translucent, almost Irish person, I understand, but I would really, really urge people to get out the fake tan bottle. Just find one that you like and use that one.
You mentioned smoking there a second ago. I don't think that people really understand what smoking does to your skin as well. We had a big campaign in Australia decades ago that showed, facial ageing through smoking. What does it do to your skin, and do people understand it?
The nicotine affects the vasculature in your capillaries, so it basically is kind of stealing all of the nutrients from your skin. Time you just look grayer and duller, and your skin doesn't look so healthy, and there's not as much vitality. We see it a lot in skin surgery, actually. When we're doing especially bigger procedures like removing skin cancers with Mohs micrographic surgery, it's a huge problem with the skin flaps failing if people are smoking. Yeah, it's a big problem. So, we try and get the smokers to stop for those couple of weeks before and after their surgery. Surgery on your face for skin cancer is quite anxiety inducing. We try to make it as easy for people as possible, but obviously it is quite anxiety inducing. So it's a difficult time for people to give up the cigarettes. But, even that little impact, we will tell people that their graft will fail or their flap will fail, that it will die basically if they smoke, and we see it happening all the time. There are increased risk of infection, all sorts of things, but smoking is a problem for the skin.
I think the other interesting thing about smoking is we all know smoking causes damage to the lungs and causes emphysema, which is a disease of the lungs where the lungs become stiff and they can't breathe very well because the lungs become stiff, loses elasticity in the lungs. But we also have loss of elasticity in the skin, where the skin becomes wrinkly, less elastic, doesn't have the rebound. So really, you can think of damage from smoking and loss of elasticity is a bit like emphysema in the skin. So you're losing the elastic function in your skin from smoking, just as we lose it in the lungs, the other organ system, which people kind of understand a bit better.
The other things that make us perceive that we look older, what are those kinds of things? When we look at somebody, is it, teeth, is it all just about skin? What else?
Oh, well, facial aging is actually very complex. So skin plays a key role and wrinkles play a key role, but we have changes in other anatomical levels of our skin. We lose subcutaneous fat, our bones atrophy, we lose bony support. So everything, in the face, as with the rest of the body, kind of flattens and goes south.
Yes,
but the skin plays a critical role in sort of the facial appearance and contributes significantly to the appearance of aging.
You've done some work on the perceptions of age. When is it that we actually start to notice those aging changes? And are there differences between different ethnic groups?
I think skin diversity is such an important topic. And, a lot of the original work was done on white skin, but we are now developing a greater understanding in different skin types and skin of colors. So I told you chronologic aging really depends on the genetics. So the baseline skin in darker pigmented individuals is different than in very fair individuals. So we know in, for example, very dark skin tones, people with black skin, the involutions between the top layer, the epidermis, and the deeper layer, the dermis, are much more convoluted. So there's a much more surface area contact between the epidermis and dermis. And the fiber...
Well, you mean involutions? You mean we used to have everything was nice and smooth before, and now we've got this sort of...
So we all have some undulation at the dermal-epidermal junction, but in darker skin, the involutions are greater. So it's a much more serpiginous interface. And that allows for better contact between the top and bottom layer of the skin. And we also know in the dermis, the deeper layer of the skin, in darker skinned individuals, the cell type, the fibroblasts, are more robust. They're producing more collagen and elastin. So the baseline for people with darker skin type is a bit more robust in terms of dermal turgor, and also
What do you mean by dermal turgor?
dermal turgor, so elasticity and strength in the skin. So when we get damage to that in white skin, it happens sooner and becomes more evident because the baseline is less robust.
You were saying earlier that the changes in skin like mine, I'd be noticing these when I was in my 30s or 40s. But is that with different ethnic groups? Do they
Yes.
notice they're aging at different times?
So there's been good data to suggest that the histological evidence of photoaging breakdown in the dermis in women in white skin is in their 40s, and that's been backed up through genomic profiling, looking at the genes that change, as well as histological studies. In darker skin types, we know the perception of aging occurs 10 years later in sort of more medium pigmented skin, so Asian and Far East Asian skin. Women tend to self-declare aging, signs of moderate to severe aging in their 50s rather than their 40s. And in darker skin types, in black skin, the women tend to report moderate to severe aging a decade later in their 60s. So it's sort of 40s when women notice it themselves in white skin, 50s in sort of medium, sort of Asian, Far East Asian skin types, and then women with darker skin, with black skin, it's really not till their 60s where they perceive signs of aging. And again, I believe that has to do with the genetic differences at baseline.
Wow. So does this mean that in practical terms, so like if you've got, different people in your clinic and they're asking what should I use, does that mean that there's a different skincare regime for people at different
stages of their
then?
lives?
Yeah.
Yes, absolutely. Mara said people generally start to notice in their 40s, and that's generally when people come in. I mean, people go through, especially women, a lot of life changes in their 40s. They might have young kids or kids growing up, or, there's a lot of flux and change, and people can be going through perimenopause, things like that. So it's often a time that people notice changes in their skin and do come in for either aesthetic procedures or for skin checks. All throughout life, we recommend SPF and sunblock. As we age, it depends on what stage you're at as to what kind of active ingredients we're adding into people's skincare routines. But generally, it makes sense to start using active ingredients in the 30s, and then maybe stronger actives like the prescriptions for retinoids in your 40s and onwards.
And I would say the manifestations of skin aging can differ amongst different skin types. So in pale skin, we might notice wrinkles and sagging of the skin, whereas in darker skin types, it tends to be pigmentation that presents initially or as an initial sign of skin aging. So with darker skin types, products that would address pigmentation may be more relevant than addressing the wrinkles themselves.
You mentioned earlier as well glycation, sugar. I mean, we sort of hear that, my God, if you have any sugar in your diet, you're basically going to age 1,000,000 years by tomorrow morning. What's going on there? Where do people draw the line? Do you have to cut sugar out of your diet? Is it just sugar alone, or what's going on?
I think we all know a healthy diet is best for our bodies in general, including our skin. So eating the rainbow, lots of vegetables, a variety of foods is what's desirable. What we do know is high sugar diet, high glycemic index foods will impact the fibroblasts. So the glycation end products will attach to the fibroblasts and impair their production of collagen and elastin. So I've told you the fibroblasts are the key cells in the dermis that provide structure, strength, elasticity, and turgor. And by inhibiting that function, we can have early wrinkling. So I think it's, people can get quite obsessive about their diet. I think keeping it general, common sense is what's in order, but we definitely know having what we call the Mediterranean diet is good for our bodies, and that includes our skin.
Telomeres. This is the other thing that is an interesting one. I remember doing a program many years ago on Dolly the sheep. And when Dolly the sheep, remember the clone sheep?
Yes.
And they were wondering when Dolly was born how long Dolly would last, because they found that her telomeres were shorter.
Yes.
So what are telomeres and why are they important? And does sugar affect those telomeres?
Well, the telomeres are sort of the protective ends to our DNA. So if you think about the cap on a shoelace, the telomeres are the protective ends on our DNA. And telomere shortening is one of the markers we use for aging. So, we assume with telomere shortening, the cell is aging, and then, functionality might drop off. So we definitely know some environmental factors like chronic high stress shortens telomeres in an accelerated fashion. So one of the theories of aging is with telomere shortening that will be correlated with cell death and accelerated or premature aging. So that's how the telomere story fits in.
Wow, interesting. Sleep and stress, actually, that's another thing too. So stress itself, why does stress do it? Is it a cortisol level, or what's going on with the stress?
So with stress, we know the skin itself is an endocrine organ. It produces hormone. It's required for production of vitamin D, and it also responds to different hormones in the body. So high adrenaline, high cortisol, we know impairs the skin barrier function, and the skin barrier is a critical action the skin is performing to prevent bad stuff from coming in and from keeping our skin moist. So impaired barrier function will lead to increased sensitivity, increased irritation, dryness, and poorer appearance due to dry skin and aging in that way.
Sensitive skin, now this is a really interesting thing, because around about 70% of people say that they have sensitive skin, and we know that as we get sort of around that sort of perimenopausal, menopausal stage, a lot of women will say, I didn't have sensitive skin, but now I do. So what's behind sensitive skin, and why does it change over time?
Sensitive skin is a really challenging topic because we don't have a clear marker, a scientific marker or a clinical test we can do for sensitive skin. It's basically self-reported, so patients will tell us my skin is sensitive or highly reactive. So the incidence, how common sensitive skin is extremely variable depending on what study you look at, but some studies have suggested even 70% of the population has reported sensitive skin at some time. But again, it's very complex. It has to do with barrier function, so if the barrier is weak, irritants will penetrate more easily and the body then reacts. Sensitive skin is a neurologic function, so the superficial nerve fibers are perceiving stimulation, maybe inappropriately, and even how our brain processes those signals can be altered in people who are claiming to have sensitive skin.
You've seen that on MRIs, yeah?
Yes, so it's people who have sensitive skin, studies have demonstrated the parts of the brain that light up on MRI scans is different. So there's clearly something different in the processing of the stimulation from the peripheral nerves. In addition, the vasculature is affected, so we know the way the blood vessels in the very superficial skin can be distributed in a different way. Those who have sensitive skin compared to those who don't feel they have sensitive skin, and that's possibly where the menopausal symptoms with flushing and increased activity of vasculature can impact. So it's a very complex topic, but it's definitely something that is relevant and can change during different phases in one's life. So as the barrier function becomes impaired, maybe in the winter months or with emotional stress or poor sleep, one's skin may be more sensitive at those points in life.
Is it just a cosmetic thing? Or you must have a lot of people coming into your clinic sort of going, oh my God, my skin is so sensitive and it's awful, I'm really worried about it because it looks dreadful. Does it matter if does it actually matter to the skin itself? Is it cosmetic, or should they actually be worried?
I think if it rolls over into, barrier dysfunction, and then you can have very dry skin, and then that can lead to dermatitis, then that is obviously an issue. But sensitivity itself in the skin is a problem because it affects people on a day-to-day basis, so it affects their quality of life. And I think as dermatologists, because we haven't had good treatments in the past, we may have dismissed it before. So I think it's very important that we listen to our patients and understand what they're telling us when they speak about skin sensitivity. It's often something that GPs, I think, have to probably deal with more than dermatologists, because they don't get to that point where they come to see us. So the fact that there's nearly up to 70% of people who have it in their lives, a huge figure. But, so I think it's something that we're learning more about. And now that we have this term sensitive skin syndrome, I think, we're going to start investigating it more. And those MRI images are fascinating.
Yeah, yeah. Are we doing this to ourselves in many ways? Because you can often think that, oh my God, my skin's sensitive or it's dry,
Yeah,
but I'm going to
yeah,
put more stuff on
yeah,
it, and I'm going to... Do we end up actually
yeah.
making things worse by
Yeah, so there's
over-treating ourselves?
definitely a spectrum. There are people who can withstand much more treatments and can use lots of different actives on their skin. I mean, typically we see that, say, when we're prescribing topical retinoids for people. Some people can tolerate very high strength topical retinoids and use them every day. Most people can't, sit somewhere in the middle, and then there is a subgroup of people who just can't tolerate them at all. They can't be in a room with a retinoid, or their skin sensitizes. So it's very, very variable for the individual. But yes, I think we maybe are seeing a bit more of it, possibly because there seems to be a lot of active ingredients now in so many different products, from general moisturizers to even wash-off products. A lot of things have salicylic acid, niacinamide. So I think possibly we are exposing ourselves a lot more to these active ingredients all the time, even if we're not unaware of it. And I think that, when I say to people, do you have a complicated routine? And oftentimes they say no. And then when I ask them about it, they have, a 5-step routine where they're using serums and lots of different things. So I think definitely people are using a lot more skincare products than previously, and that has an impact on our skin.
And I'd also like to add, I think younger people are exposing themselves to more products at an earlier age. So, we talked about the immune system. The immune system in our skin is a memory. So when we're constantly exposing ourselves to different antigens or chemicals or products, our memory cells might finally change over to an allergic response. So it's a big marketing campaign to push products onto young people. And anti-aging products, retinoids, salicylic acid, when our skin is young, it's robust enough to repair damage by itself. So there's no point in using these products on skin that's already healthy, and your own natural repair mechanisms are already taking care of any problems from UV, really. So I think that's an important message.
But I guess you're really battling against that marketing hype then, aren't you, of the it's prevention. You've got to take it for prevention. So basically what you're saying is that it's already doing it itself. You don't need to add more because it's already preventing that as it is.
Your body's repair mechanisms are very robust even into your 20s. So really it's good sun protection in young people, possibly in your 20s, maybe an antioxidant to help shift the balance. But we really want to avoid pushing lots of products on our teens unless they have skin problems like acne. And I really think it sort of in a way exploits the vulnerability. Young people really don't want to miss out. They want to optimize everything in their life, and it can be quite destructive. And young people are vulnerable to obsessive thinking sometimes and rumination, and it can become quite unhealthy. So I think that's really something as a society we have to be aware of and try to guard against.
Yeah, it must be incredibly hard for parents to tell, their 12, 13, 14-year-old that they don't need something when they've got every other kid in the room going, well, I'm using it, and they end up being the odd one out, and they feel like they're just not getting what they need, and you're standing in their way. Difficult.
In my house, because I just have the line, well, your mummy's a dermatologist, that usually works. But I always think with these things, you can't deny your kids everything all the time. So you can kind of say, look, you can have that as a treat, when for your birthday or when your auntie buys it for you for Christmas, that's fine. But day to day on a regular basis, it's just the bland moisturizers and SPF. I mean, if you're getting SPF on them, you're doing, sunscreen on them, you're doing a good job.
When you get to my age, though, coming back on target here, and you do have that sensitive skin, then what do you advise people? How should they actually sort of get it back to a nice calm place?
Well, I think with sensitive skin, the name of the game is really reining things in. So really minimizing products, because you don't know what's triggering this response, and depending on what your baseline is at different times, products you might be able to tolerate it one day might be irritating or cause sensitivities another day. So it's really paring back the routine to even just using plain water as an emollient, to wash, or using a soap substitute as a cleanser, and then just a bland moisturizer to, again, try to promote a healthy skin barrier. But if anything you're putting on, even a sensitive skin moisturizer, is causing stinging, then that's a problem.
Ceramides, those kinds of things, I mean, things that have got a nice sort of lipidy kind of base in them, are they sort of useful sort of fallback on things?
So ceramides are a lipid, a type of fat in our skin, in the top layer, the stratum corneum. So it's a key lipid to help keep a healthy skin barrier. So there are a lot of good moisturizing products and emollients that have ceramides to try to replace ceramides that may be lost, or in patients that have a low level of baseline ceramide. So that's the science behind ceramides used in moisturizers.
Yeah. Just want to bring you back to diversity for a bit of a section there. Do we know enough about the different tolerances in different types of skin as well?
Well, even though I told you the dermis is more robust in darker skin types, that's the deeper layer of the skin, we know the actual barrier function is weaker. So in black skin, the transepidermal water loss, which measures how much water is lost from the skin, indicating a weaker barrier, the transepidermal water loss is actually greater. So the dermis is very robust, for example, in black skin, but the stratum corneum, the barrier function is weaker, so they often have more dry skin. So with a weaker barrier, an individual may be less tolerant to salicylic acids, to retinoids and type of peeling products or astringent products. So I think there needs to be a lot more research into the diversity of skin types, and certainly we know in dermatology darker skin types are less well represented in basic teaching materials, for example, in medical school and for GPs, etc. So it is quite complex.
So when you're actually innovating products as well, when it comes to your wonderful work with the Skin Diary, how do you go about thinking, I need to make something that's going to work for all?
Well, one of our key goals when we developed night repair therapies is producing a product that was well tolerated. So even though, our studies have demonstrated a high level of efficacy through double-blinded randomized placebo-controlled trials, the product is extremely well tolerated. So if patients who have eczema, patients with sensitive skin, patients who've not been able to tolerate the traditional retinols, love this product because it is very well tolerated, and it's not a single ingredient. It's the synergy of active ingredients that we've included in the cream that help support each other and provide strengthen the skin barrier, reduce inflammation, and tends to be very well tolerated. It's a product that can be used on the face, but also the neck and hands, which are areas that can't tolerate retinols very well at all.
Now, speaking of retinols then, so we have this scale, don't we, where we've got the sort of esters at one end and then we've got tretinoin and the prescription big one at the other end. Marketing will tell us that we basically need to up our retinoid from, start with an ester, then we move on to a retinol, then we move on to a retinaldehyde, and then we'll do a tretinoin, and we've got to keep on upping it. But you've gone for an ester in this night cream. Why was that?
We wanted to avoid, obviously we couldn't use tretinoin, which is a pharmaceutical prescription product, and retinols are in a number of products, but we also know cause irritation. So we went for an ester, which we know would be very well tolerated, and on its own may not have the same impact as, for example, retinol or all-trans-retinoic acid. But in the unique formulation, we've demonstrated that all the actives work in a synergistic way to give results comparable or better than all-trans-retinoic acid, the prescription strength product, in repair of fibrillin and elastic fiber and in repair of collagen.
You've also got hyaluronic acid in there as well. Now, are all hyaluronic acids born equal? Because again, there are different weights and molecule sizes and things like that. What is it about the one that you've chosen in particular?
So we were very careful when choosing HA, because HA is in every product. It's a wonderful humectant, and that's why it's in lots of products. In fact, it's used to inject into the skin in dermal fillers. So, it is a wonderful molecule, but different weights will have different impact. And we know that the medium chain weight of hyaluronic acid not only impacts the superficial epidermis, creating moisture in the superficial skin, it actually, through chemical signaling, will improve collagen and elastin and have an effect in the dermis. So the HA chains that we've chose have both superficial effect, but we're actually the right chain lengths to impact dermis through CD44 receptors and improve collagen and elastin production. So the HA in these products are also working at a deeper level, not just at a superficial level on the epidermis.
And you managed to get them to cross the skin barrier?
It's not necessarily that they cross the skin barrier, but through chemical signaling will impact the dermis. So it's really through the cascade of chemical signaling or cytokines that will produce repair of the collagen and elastin.
You've also got a bit fruity in there as well. You've got your bits of tomatoes, lipocene, lipocene or lipocene?
Lycopene.
Lycopene, there you go. Neither. And bilberry as well.
Yeah.
So why those, and what evidence is there behind them?
Well, we know antioxidants are critical in terms of repairing damage and preventing damage in the cascade of intrinsic and extrinsic aging. And the bilberry story really is anecdotal. It goes back to our roots in the Northwest, and we had holidays in Wales, in North Wales, many summers, and we used to go bilberry picking. Bilberries are a wild shrub that grows on sort of moorlands in the hills of Wales. And whenever we went bilberry picking, our fingers and our children's fingers were stained purple or blue. So we knew that they must be very high in antioxidants. And in fact, when we investigated, bilberry is one of the botanical ingredients that has one of the highest antioxidant potential. And also lycopene is in tomato skin. And we also understood through studies done at the University of Manchester that lycopene was very effective in reducing sunburns and having a good antioxidant effect. So those are the two we went for, including in our product.
You also got niacinamide, which you'd mentioned before. Why that?
Niacinamide, again, is a great all-round anti-inflammatory agent. So it works at multiple levels in the intrinsic and extrinsic aging cascades to help repair, provide building blocks to prevent the cascade of damage. So due to our background understanding in skin aging and the processes at play, we chose all of these actives: anti-inflammatory, antioxidants, hyaluronic acid, retinoids, to work synergistically in a very acceptable, well-tolerated formulation to get the results that we've subsequently proven.
There's some really fascinating research on niacinamide, specifically when it's formulated with the medium-chain hyaluronic acids. It's been shown to have a xenomorphic effect, so that's the older cells that won't die off and are still in your skin secreting all of these nasties. Something that's xenomorphic basically switches them back into being a healthy younger cell. So, this is where the science with all of these ingredients and active ingredients is going. We're learning a lot about how they're actually changing the kind of epigenetic functioning of the cells to reverse them into behaving like younger cells. So we're really on the cusp of some really interesting new treatments in dermatology in the sphere of aging.
Wow.
And this is all stemming from the movement in regenerative medicine and longevity medicine, which is, again, embraced in many other organ systems.
Yeah, absolutely. You mentioned testing there before. What testing? I mean, there will be those who will say, well, a manufacturer's test, it doesn't really mean anything to me anyway. But you have done some quite extensive testing with this, including histology components to it. So what have you done and what has it shown?
Because of our background in science and using drugs to improve skin disease, we approached the testing of this product in the same way. So we used a very rigorous standard of testing, including double-blinded, placebo-controlled trials. And what the study did is placed the product alongside a vehicle, just a plain moisturizer, tretinoin, and nothing. So those four components were placed on patient skin and then subsequently biopsied. And the biopsies test for a number of things, including fibrillin, which is the elastic fiber, and collagen. And we were able to demonstrate that actually the repair and the production of the fibrillin microfibrils and collagen were on par with the tretinoin, statistically significant compared to baseline or vehicle. So that kind of rigorous approach really convinced us as dermatologists and skincare scientists that the formulation in that product actually worked through synergistic mechanisms. We subsequently went on to do the clinical study, which demonstrated patients before and after using the product, and again, very convincing results at 3 months and 6 months. And we chose people who were severely photodamaged, so we really wanted to demonstrate efficacy or effectiveness. The clinical trial we did on forearm skin used a small number of patients, but even using such a small number of patients demonstrating significant effect shows the power of that treatment. it's good science that we produced, and really excited that it came up with the results that it did.
It's a really fantastic study. So each of the patients, obviously, that were included, they act as their own control, so you have that as a baseline. But the University of Manchester is a great place to test a skincare product because they have years of experience. But also there's a very unique setup there where, you have all of these scientists who have lots of experience in skin aging and in researching skin and aging products, but you also have the ability to get human skin, so there's patients from the hospital who are willing to donate their skin for testing. So it's a really unique setup, which, isn't replicated in any centres in the world that I really know of.
And I think that's what makes it unique. Our test was done on real human volunteers with photo-damaged skin. It wasn't done on 3D skin. It wasn't done on pig skin. It wasn't done on fibroblasts in a dish. It was actually done on human forearm skin where we took biopsies. And, we had to get ethical approval through the university. We had to get proof of principal funding. So there was a lot of work that went into delivering that study. And it's something that we're really proud of and pleased that the results showed what we hoped.
It's interesting as well because it was really approached, well, maybe this will work, maybe it won't, and if it doesn't, it doesn't. So it wasn't approached in the usual fashion a skincare product would be, and that would be, that a marketing team come up with a concept and then the product is produced from there. This product was really built from the ground up by the team. I've heard Chris say, they didn't really expect to get the results that they expected to get. So it's really great. And I think it's really set the standard, it set the bar for this kind of testing for skin aging products. And it's really set the bar because now we realise how important this research is, much more important than we originally thought, which was just at a cosmetic level, looking at wrinkles and improving people's appearance. It is now very relevant for skin health that we have this information from this type of research.
And the basic science research on the fibrillin microfibril really was pioneered in Manchester over decades. So Professor Chris Griffiths, Professor Rachel Watson, the fibrillin microfibril concept, that is the canary in the coal mine. So if you see damage, that's what the beginning of the damage, and if you see repair, that is the beginnings of the repair and a good indication that the repair will continue. So that whole concept of the fibrillin microfibrils was work through Manchester, it's really decades of research.
Wow, it's amazing, isn't it? When you both started your careers, did you ever actually think this is what you'd be doing in 20 years' time or so?
Well, when I started, that was a long time ago. And my goal at that time was just to become a dermatologist.
Was I being generous when I only said 20 years?
I think, starting off in dermatology, the goal, it's always one step, and the goal is to become a consultant or an attending, as I was training in the States to get my qualification in dermatology. But, life has interesting twists and turns. And again, we're just delighted that a concept that we had has now come to fruition and come to market with a scientific backing that we're satisfied with as consultant dermatologists and skin scientists.
And is it just for people with aging skin, or since we've spoken about sensitive skin as well, can people with sensitive skin use it too?
People with sensitive skin, it's more likely they will be able to tolerate this compared to a retinol. But people can still be sensitive to very bland products. But if a person is struggling with sensitive skin and wants to use a sort of more anti-aging or skin health product, it's something with cosmetic actives, it's something that may be a good place to start. But again, it would be up to the individual response. But again, I've had patients with severe eczema. They love it. They tolerate it really well. And they're also really happy because, particularly middle-aged women or older with eczema, they feel like they're aging disproportionately because their skin is inflamed and irritated, and they're not able to use, the products that could repair or postpone some of the signs of aging. And this is something that they might be able to reach for. But again, I would always say it's very individual.
I'm not going to ask you whether or not Clare was or wasn't a good student in your Masters for Ageing, because I'm sure she was exemplary.
She got distinction.
Did she really? But out of that grew a need for you obviously saw that, this is a wild west out there in terms of what's going on. We've got people, basically you can go to a plumber and get filler done. We've got people doing fat transfers in their backyard. Basically, it is literally the Wild West out there. You've been working very hard in trying to get change in that particular area. Why do you think that's important, and where are we at?
Well, this has been, again, another decades-long issue that we've been trying to improve and change, but it really stemmed from government deregulation of cosmetic procedures, and that occurred in 2008. So in 2008, the government deregulated procedures that were deemed cosmetic and also some forms of laser and light-based therapy. And as dermatologists, this was extremely concerning. We knew these procedures, many of them which were developed to treat disease, were now being used in the cosmetic arena, but the intrinsic risks of the procedures themselves were the same. So just because a procedure was used for cosmetic reasons doesn't mean it didn't have any risk. It still had a risk, and that risk wasn't recognized, and we knew it was causing harm to patients and the public because we could see patients coming to us in the NHS who had side effects, adverse events from procedures done in the hands of a practitioner who possibly just wasn't trained. And this was allowed, and this is what was happening. So we subsequently, it was dermatologists and plastic surgeon colleagues that really tried to get together to develop some kind of regulatory frameworks for this type of practice to improve patient safety. But it wasn't until the PIP breast implant scandal, which affected over 40,000 women in the UK and almost 500,000 worldwide using fraudulent industrial grade silicone in breast implants with subsequent huge amounts of problems. It was a red flag for the government saying this is absolutely out of control. And they commissioned Sir Bruce Keogh, who at the time was the medical director of the NHS, to do a review of the regulation of cosmetic interventions, which I was involved in contributing to, as were a number of other dermatology and plastic surgery colleagues. And that review demonstrated that actually 75% of the market share of cosmetic interventions was not the surgical breast implants, tummy tucks, facelifts, but it actually was a non-surgical sector, so injectables and laser treatments. But there was no regulation, and patients were coming to devastating, life-changing, long-standing harm. And he recommended mandatory regulation. But at that time, the government wasn't particularly receptive to mandatory regulation, but they did agree standardized, high-level educational frameworks would be required. So at that time, I and others were very involved in developing training frameworks through Health Education England, which is the government's body that developed educational programs for in medicine and other healthcare professions. So we developed the training frameworks through Health Education England, but it wasn't regulated. So these were the frameworks that people were recommended to follow, but people didn't have to. So it was a little bit of a double standard. And at that time, we developed the Masters in Manchester really as an answer to say, look, this is what we feel as dermatologists is the gold standard and the minimum requirement for anybody who wants to practice in this arena. And yes, there are still weekend courses, half-day courses on these types of treatments. That's fine. We don't agree with it. We understand they're going on, but this is the gold standard. We drew a line in the sand to say this is what we feel is adequate education. And since that time, the program's gone from strength to strength. We've had over 200 students, but our course takes doctors and dentists, like GMC and GDC regulated individuals. So that's the education side of the story. In terms of the licensing, we have managed, again, after decades, to get a change in primary legislation. So this is an amendment to the Health and Social Care Bill. And again, it's a once-in-a-generation change. So it was a tremendous achievement, and it was through working with multiple stakeholders. We developed the Cosmetic Practice Standards Authority, the CPSA, which was a group that developed standards for clinical practice and education for different procedures in this arena, aligned with the JCCP, the Joint Council of Cosmetic Practitioners, and it was sort of the brother-sister voluntary regulatory groups. The JCCP developed a register, so practitioners would be checked against the standards that we developed in the CPSA in solidarity to say this group of practitioners has agreed to follow the CPSA standards. They work with integrity, and they're upholding the professional and the training standards agreed with JCCP and CPSA. So that has moved on now, and we're in a stage where mandatory licensing, the government is now allowed to do that with the Health and Social Care Bill amendment, but the consultation is still underway, and we're still trying to agree what is in scope of the licensing practitioners and premises will be licensing, so this fly-by-night, fly-in, fly-out sort of practitioner will be discouraged.
Let us hope.
Yeah. The traveling practitioner, licensing will apply to the individual as well as the premises. But again, it's in flux. We've made great headway in getting change to primary legislation, but the actual implementation is still in discussion and in consultation.
Do you think the government's proposal to put VAT then on nurses doing cosmetic practitioner type work is going to force more people into what Clare was referring to before, the type of practitioner who's converted his fish and chip truck to do fillers in? If they're making those prices higher, is that going to drive more people away from actually people who've got some sort of form of qualification?
Well, there is a cap. So if you're a healthcare professional engaging in cosmetic work, you can work up to the VAT cap before you're charged for VAT. I think the VAT issue is very controversial, and with regulation incurs expense. So there will need to be CQC, an expansion of CQC checking the sort of more risky red light procedures. There will be environmental health agents that need to go around checking the amber and the green procedures. So there's a lot of work and expense and regulation, and I suppose the government is trying to fund some of that.
Yeah. You've also done some work then on, basically if we have a situation in a country where a plumber can set up and say, I can do this, we also have a situation in this country where pretty much anybody can call themselves a dermatologist or a cosmetic dermatologist or a consultant dermatologist. There doesn't appear to be a lot of regulation on what you can call yourself. Same with plastic surgeons, I believe, as well. So you've set up a sort of the blue tick sort of system. So what's it for? How do people know what it means, and where do they find it?
The consultant tick was really developed to promote transparency. So there are many healthcare providers that have different qualifications. There's many people that see patients with skin disease or people with skin problems. Even people working at the cosmetic counter will advise pharmacists, advise people on skin conditions. But we really wanted to, again, make it transparent so members of the public and patients knew who they were seeing. And in the U.S., we've got board-certified dermatologists. It's a very easy concept for people and patients to understand. If they're seeing a board-certified dermatologist, that means they have gone through medical school, postgraduate dermatology training, possibly even a fellowship. So years and years of training to acquire skills in the breadth and depth of issues relating to skin disease, the scalp, hair, and nails. Is also skin health. So that is a high level of expertise. But in the UK, patients often were confused because they felt they saw a dermatologist, but as we know, it was someone with a different level of training. And it's not to criticize other groups. We certainly support all healthcare professionals to provide good care, dermatology advice to our patients, but it's really to make it transparent to patients that if someone has the consultant dermatologist tick, which is linked to their GMC number, and again, this doesn't roll off the tongue like board certified, but to have achieved that level of expertise and training, we're on the GMC specialist register for dermatology, so it's complex wording, but by seeing the blue tick with the individual's GMC number that says GMC specialist registered, then patients and either other healthcare providers, trusts can recognize the qualifications quite easily of that individual.
Yeah, that's an important thing. Brilliant. Thank you. Thank you for that work, actually, because it really does need to be done. Thank you both. Thank you, Tamara. That was really interesting. Amazing stuff. Skin is so complicated. And thank you, Claire.
Yeah, we could talk about it all day.
Absolutely. Thank you for joining the Skin Diary podcast today, and we'll see you next time.